So let's start. Hello, everybody. My name is Veiko Vengerfeldt, and I'm an endodontist. I'm an endodontist, so why do I want to talk about implantology? So first of all, of course, I want to thank Megagen for the great opportunity that they gave me to give a presentation, and I'm very happy because of that. So thank you, everybody. I come from Estonia. So Estonia is a very small country in northern Europe. And you can see from the map of Europe, it's very close to Finland, Latvia, and Russia. So we are very small. We have only a little bit more than 1 million citizens in the whole nation. And I particularly come from a small town called Tartu, which is, again, compared to Estonia, it's quite big, but compared to the rest of the world, it's a very small town. It's only about 100,000 citizens. And Tartu is very nice town. It's university town, and we have a very old university already since 1632, if I'm not mistaken. And I also teach at the university. I teach cardiology and endodontics to the 3rd, 4th, and 5th year students. So Estonia by itself is a very nice country. We have 4 seasons. We have a lot of nice old towns, like here, it's the old town of Tallinn, our capital. We have wintertime, which can be quite cold. This is an overview of Tartu, so my hometown. You can see town hall, and next building to the town hall at the moment is Clinic of Dentistry. So I'm in the middle of the city when I'm working with my students. We can have, again, a very snowy winters, and sometimes it's quite difficult to drive or to walk on the streets. But basically, we have very nice nature. We have bogs, we have a lot of forest, we have sea. Unfortunately, we do not have any mountains, but like we are used to it already. So what is the interesting thing in Estonia? We can have ice roads over the seas. You can take a car and you can drive over the sea, let's say, to the next city, usually, or to some islands. You can take a car sometimes, or you can take a ferry boat sometimes. So you have different ways to get from one place to another place. Unfortunately, you can take sometimes the wrong way, and taking the ice road with your car is sometimes very dangerous. The ice can break and you can fall. So I think it's quite similar with dentistry, that you can take, sometimes you have different ways of doing things, but you can choose wrongly, even if you think you planned everything very carefully. So this is, again, summer times, which is very nice. So if there will be a possibility in future, I invite you to all to here. So the red part is the windows where I do work on the right side. So I work right in city center, in an old building. And it's really nice in spring and autumn time when the students are coming to the town again. I like dentistry really much, very much. This is my passion, and I have also a private practice where I work. I do a lot of different treatments in my clinic. The clinic is quite new. It's not it's a little bit more than 2 years old now, and this is my lovely assistant assisting me at the moment. As you can see, we are doing a root canal treatment, conventional way. I have quite plain setup in my clinic, but every cabinet has a lot of monitors. We have in every cabinet we have a microscope, dental microscope, and I think the dental microscope is a game changer in dentistry. I was very happy to be taught by my professor, and I worked with him for many years in his private practice also. And this is my first microscope that I used. Actually, this was my professor's microscope, but I started using Zeiss microscope, and I was very happy. So today I don't use Zeiss microscopes anymore, but it doesn't matter. I still think it doesn't matter so much what brand to use, but still you have to use in every field of dentistry, especially endodontics. So we don't have very good scientific background about the use of the benefits of the microscope in dentistry, but we don't have to have scientific evidence. We can have a self-evidence, and my self-evidence is telling me that microscope in endodontics and other parts of dentistry is a must. So that's why I do everything with dental microscope. I do a lot of surgery. I do a lot of surgery about endodontic surgery, apicectomies, and different treatments also in surgery. And I do last, let's say, 13 years already also implantology surgery. I also teach my postgraduate students at the University of Tartu, and some of my postgraduate students are coming to my clinic, and I can teach them like forehand dentistry. I can be an assistant, and she or he can do the treatment. So I can guide his or her hand and teach how to cut or what procedure she needs to take and how to take it. So I think it's the best way of teaching young dentists. So as you can see, we have a lot of monitors lying around, and we can see from the monitors, or the assistants or myself can see from the monitors what exactly is clinician seeing at the moment. So as you can see, my assistant is always having a lot of fun when I'm teaching my students, because she can rest more and make some selfies and pictures, and she's a lot of fun in the office. So we all know that endodontics is a prevention and treatment of apical periodontitis. So I also did my thesis, my PhD thesis, about apical periodontitis, the prevalence and the genetic aspects. I defended my PhD 2 years ago, and I'm very proud of myself at the moment. So I want to show you some cases where I did different treatments, and maybe I will also explain some basic steps why I did it and how I did it. So the first case is a case of Ain. Ain is a male person, 45 years old, and he has a problem with tooth number 35. So we have a couple of diagnoses on the, 35. We have a couple of diagnoses, previously treated, previously endodontically treated, and abscessus apical chronic diagnose, chronic apical abscess. So this is the first X-ray that I have from his tooth. You can see a big apical lesion. You can see an intraradicular screw. You can see a bone loss in distal area. And you can see, of course, not the perfect previous dentistry. So no root canal treatment previously, and only a retention screw. So what can we do about the situation? Again, we have two possibilities at this time. We can, of course, extract the tooth and put implant. We can choose different modalities how to put implants. It's a simultaneous or an instant placement or delayed with some healing. But of course, we can try to save the tooth. We can do endodontic treatment and maybe put a crown on the tooth and therefore save the tooth and the root this way. So what was the problem? The problem was that the patient was a referral patient. The previous dentist saw the patient first. So she did a great job of removing the intraradicular screw, and she did a very good job of isolating. You can see a rubber dam clamp, and the root canal was very well cleaned. So this is how the patient came to my office. So the last two X-rays were from previous doctors. She sent me through the email, and this is the situation when the patient came to my office. So what was the problem? The problem was that the root canal was extremely wide. So you can see a 100 ISO standard file. So it's 1 millimeter at the tip, which is huge in endodontics at least. So this was a big problem. There was a big problem because end of the first visit was that patient had swelling. He had a big swelling, both sides, the lingual and buccal side, and the previous doctor needed to make an incision. So double incision and drainage was achieved. And those are the situations that quite seldom go by very well. So usually, if you have if you need to make a double incision, so a buccal side, a lingual side, so the tooth usually have not the long-term life expectancy, and usually you need, or we need to take those teeth out. So, but the patient was eager to keep the tooth. He really didn't want to lose the tooth, and he was asking the referring doctors that please try to do everything you can to save my tooth. And she did. She did a very nice job. She opened the tooth, she made incisions, a drainage, put some calcium hydroxide in the tooth, closed the tooth with temporary filling, and she did the best, but she was thinking that she's not able to help him more, and she referred the patient to me. So this is how the patient came to my office. I made an X-ray, and you can see a lot of calcium hydroxide is already gone from the root canals, so it's resorbed. And what we did, we isolated the tooth with rubber dam very heavily. We used a lot of flowable rubber dam and also things, and we made a very good irrigation. We tried to make, like this time, a surgery tip endo irrigation needle and like a custom-made endovac. I have a confession to make. I also speak or make some lectures to the company named Koltene. So you can see in some places some products from them also. So, but the main thing is we try to irrigate a lot, because chemomechanically or just mechanically we couldn't make the root canal any larger. As you remember, you saw the root canal was already more than 100 ISO standard large, so it's huge already. So we tried to clean it as well as possible. We also brushed with some endotims, which are also a very nice product, which you can brush like an applicator. And then we have to fill the root canals after the root canal system is very well cleaned and disinfected. You can use different filling materials, but basically all of them are MTA based. So we have a lot of MTAs or bioceramic based materials today. So there are some benefits over another. So my preferred choice at the moment would be to choose a total fill or endosequence. But of course, this is only my private and my choice. So if you like something else, you can use something else. Still powder, MTA powder with distilled water is a classical approach, and you have to mix it very well. You have to make it ready like wet sand. You have different colors also. You have gray MTA, white MTA, so it depends of the place you want to use them, or what is your preferred choice. So you should do it with sterile equipment, sterilized spatulas and sterilized cups. And you have different application methods how to applicate. I like my old Dovgan carriers, which was based by American company Vista Dental in past, not anymore. And you have to fill the carrier with precise amount, otherwise you will not get a perfect MTA bullet or pellet. So you have to have precise amount of the materials, and it's rather difficult to handle the material. Of course, you can use some spatulas, and you can use some special devices to make the special MTA pellet. So how do we applicate it? We take a carrier, we will put some material in the root canal, and we will try to plugger it down. You can plugger it down with endodontic pluggers, or you can, of course, choose paper points for that reason. So we have different systems on the market you can choose, but this here is still my preferred choice. So we have a 30 block, which also can be custom made by yourself. And this is especially handy when you do apical surgery and you want to make a retrograde root filling material. So, but again, if you put an MTA in the root canal or any other bioceramic material, you have to blugger it down very well. You have to condense it well to avoid any kind of air bubble. How to do it? You can use a blugger, endodontic blugger, and you can touch a tip or you can touch endodontic blugger with ultrasonic tip. So this is already being described by Lovely in 2004. So you can take a ultrasonic tip and you can touch a tip with a plugger, and you can condense the MTA quite well. So this is how I did it. We took some MTA and we vibrated with ultrasonic and moist paper points to the correct length. Unfortunately, you can see we got some extrusion of some material. There are some techniques to avoid this, but this time I made a little mistake, and I was not making a periapical barrier. So a little bit of some material went through, but you can see it's not a big problem. So what I did next was I covered the MTA with moist cotton pellet, and I closed the tooth with some temporary filling material and some glass ionomer cement also. So now you can see after the visit, after this visit, root canal filling with MTA type of cement. You can see where the cotton pellet is, because this is radiolucent, and you can see some temporary filling on top. So already you can see that you can see some healing of the periapical lesion. So the next step in the next appointment was to restore the tooth or to close it. So I removed also temporary filling, I removed the cotton pellet, and we inserted fiber post and composite, dual curing composite material for the core. So this is how the patient looks, and this is all already 4 or 5 months after first visit, and you can see root canal filling with MTA, fiber post, and core material. So then, of course, everything was good, and the patient had no pain anymore, no swelling anymore, and he was lost. Only he came back only after 2 years. So after 2 years, you can see I made an X-ray, periapical X-ray, and we can see a total resolution of the apical radiolucency. So the endodontic treatment was a great success since this time. So we made a crown after that, and the patient was very happy. So this is how we started, and this is how we ended. So you can see we had a very good result and success rate in endodontics if we're doing everything correct, even in very difficult situations. And if you do everything correct, you will have a perfect bone healing. So this is second case I wanted to show you today. Again, an endodontic case, but a little bit with different diagnosis. The tooth is a little bit the same. It's 4-5. It's a lower right second premolar, and we have a pulp necrosis and a chronic apical abscess again. So this patient had a lot of problems, a lot of secondary caries, a lot of different orthodontic problems, as you can see from the photos. Also, Also some endodontic treatments that were not so well done in previously, but from the panoramic X-ray, you can see there is even more problems in his side. So you can see a sinus problem in the right side of the maxillary sinus. You can see something like a cyst in the sinus. You can see an extra tooth in maxillary frontal area. And you can see tooth number 26 has a periapical lesion. Tooth number 34 has a previous endodontic treatment and some lesion in the apical area. But the main problem in patient's mind was tooth number 45. So he had a fistula, or it's correct to say he had a sinus tract and missing first molar. So this is a sinus tracing X-ray with a good aperture in the sinus, and the sinus directs indicates that the problem is tooth 4-5, which we knew already. So you can see a sinus tract on the gingiva also. So what I did again, this time I isolate the tooth, I cleaned, and I did an endodontic treatment. I chemomechanically enlarged the root canal, and I put some calcium hydroxide in the root canal system. So you can see the calcium hydroxide on the X-ray, and you can see some calcium extruding through the apex and even through the sinus on the same visit. So I close the tooth with, I do usually double layer closure. If I do a multiple visit treatment endodontically, I use gypsum-based temporary filling in the bottom of the cavity, so like a cavity or something similar. And on top of it, I'm using glass ionomer. So after removing the rubber dam, we saw the calcium hydroxide was extruding from the sinus tract. So usually it's not a big problem, so you don't have to worry about it too much. But of course, it's not indicated to overfill the root canal. You have to be very careful because you can have some problems with those kind of treatment. And we also did, like I will show you. So this is after some months, the patient came back. We can see a lot of resolution or resorption of the calcium hydroxide in the root canal, and we can see some calcium hydroxide still in the sinus tract. So, but again, on the gingiva, the sinus tract is not visible anymore, so it's closed. So this is an indication that our endodontic treatment is working nicely, and we can control the microbes in the root canal system. So we did it once more, put some calcium hydroxide, and after that we made a root canal filling. Next visit we made a root canal filling. And as you can see, the root canal filling is also, the sealer part is a little bit extruding through the apex. It's again not a big problem if the extrusion is not great or if it's not really excessive. But of course you have to be very careful not to extrude it as a material, at least not too much. So again, after a root canal filling, we have to build up the tooth. We can use different ways of doing it. In this case, I was using glass fiber post and dual curing composite material. So this is how we finished with a root canal treatment or the endodontic treatment. So we have a root canal filling, a regular way. We have glass fiber post and a dual curing composite core. So of course we know that tooth needs to be crowned in future. But the patient had a problem also that you can see. He didn't have a tooth number 4-6, and he really wanted to make everything well in his mouth. He was quite eager to try the best he could, and also he was getting more confident as endodontic treatment went well. We can see there is no sinus tract anymore on the gingiva. We can see actually a little scar still on the gingiva, but endodontic treatment went quite well. So how to deal with a missing tooth in these situations? Of course, a lot of surgeons know that there is a bone deficiency here, and you have to augment the bone. Also, you have a little less room for the crown, so we have to make orthodontic treatment. We had to make orthodontic treatment because of different problems also. So we included orthodontic treatment in this part also. We made some room for the crown. So we know that orthodontic treatment is not making any endodontic treatment some harm. So you can do it with good confidence. So and also we know that patients want to have teeth. They don't really matter to them if they want implants or if they want an endodontic treatment. They do want teeth. So this is how we started. So pre-endodontic treatment, and this is 4 years after endodontic treatment. So we still have orthodontic treatment going on, and we still have a lot of different things we have to do for the patient. So the patient continued with the treatment, and you can see he already did a lot of other things also, or corrected some other things. And number 4-6 is already implanted and augmented. To be perfectly honest, this is not a Megagen implant, as you can see. This is an ankylosing implant, but again, and we had to augment. We had a lot of problem because of this previous sinus tract, but at the moment it's all looking quite good. So next endodontic case I wanted to share with you today is a case of Leah. She's a very nice lady. She's head of emergency ambulance in South Estonia, so very busy woman. So she had a problem with upper first molar, tooth number 1-6. It was previously treated, and she had some symptoms. And of course, she had active caries. She knew that the tooth was totally broken. She came to my office, and this is what it looked like. And I told her, sorry, Leah, I cannot help you with this teeth. This is not possible. We have to extract it, and we have to maybe put an implant to it. But she refused. She told me that she wanted to have the tooth, and if it's possible, by any means, she wants to have it, and she wants a treatment if possible. So what we did, I did a lot of pictures. This was the first X-ray. We can see the previous endodontic treatment, not perfect treatment, but a treatment indeed. And what we did, I did deep marginal acquisition. 20 years ago, it was called a gingivectomy. So I did it with a thermocut burr, which is a burr on this slide also. So this is turbine with no diamond coating. So it's like a ball shaped bird. So I removed a lot of gingiva. It's a big sin in pink aesthetics, I know, but I wanted to see the ferrula. I wanted to see if I can get the tooth and it's not karyotic, because when I removed some caries from the dentin, I saw the dentin was getting harder and harder, and I was thinking, yes, maybe I can still help her and not extract the tooth. So we did so-called gingivectomy. We isolated the pulp chamber of the previous root canal treatment with Teflon tape, and I did a very quick build-up of the core. So this is a quick build-up. You can see on the left side Teflon tape, and on the right side I removed the Teflon tape and I adjusted the access cavity. So you can see all the root canals and some previous root canal fillings also. So in this situation, we know we can proceed with endodontic treatment quite well. So what we did, we started to remove all the old root canal fillings, and we started with a chemomechanical preparation. So we removed all the old root canal fillings and we opened all the root canals. You can see the isthmus between mesiobuccal 1 and mesiobuccal 2 root canals, which is quite difficult to clean, and you have to be very meticulous of cleaning those places, because you know that in isthmuses we can have a lot of microbes, and if you have microbes in the root canal system, you will have apical periodontitis, and it will be surely be a not successful treatment. So sorry about the Estonian headline, but this is what it looked like. So when I opened the root canals through the apex, so I made an apical patency. So quite suddenly, a very clear, not water, but exudate was coming through the root canal. And you can see if I suck with an endodontic suction tip, you can have a lot of fluid coming from the root canal. And I was quite afraid that even I could clean the root canals, still the fluid was coming very heavily. So what was the problem? The problem was that we had sinusitis, sinus symptoms also. So let's go forward. What I was doing, I was sucking out the fluid as much as I could. It was not stopping, so it was coming a lot of out from the root canals, and I inserted some calcium hydrox in the root canal systems. But still, you can see the fluid is coming even if I'm pushing the calcium hydroxide in the root canals. In those situations, if I do a multiple visit endodontic treatment, I always use calcium hydroxide. So this is, I think, the only good treatment modality. So this is X-ray, periapical X-ray after calcium hydroxide, and I can see, we all can see some extrusion again of the calcium hydroxide, at least in the palatal aspect. So I was quite afraid that even so I did my part very well, at least I thought so. I cleaned the root canals and I put some medicament in the root canal. And still, she can lose the tooth because of the sinus symptoms. And I sent her, yes, this is again this dual layering temporary filling, cavity 10 plus ionomer cement. I sent the patient to CBCT, because on that time I didn't have a CBCT machine in my office. And you can see there is a lot of fluid inside maxillary sinus, and it's almost filled with sinus fluid. So we knew we had a problem. So this is a photo of the X-ray. So the next, sorry about that. So the next step is again to clean very, very well the root canal systems. So in the next visit, I was very happy to see that there was not anymore the sinus fluid coming out from the root canals. So I could make a nice chemomechanical preparation and endodontic treatment of the tooth. I could irrigate it, and I could enlarge all the root canals. So I'm using heat-treated nickel titanium instruments, so it's not so important that's at here. But again, this is an X-ray of the working length measurement, and this is how the root canal looked like after chemomechanical preparation. So we have 4 canals like we have usually. Very seldom we have 5 canals, and even sometimes we can have a little bit more than 5, or sometimes 3 canals also. So, so the second, actually already the third appointment, the third visit was filling the root canal system. So again, I was choosing an MTA-like material. This time I was using a bioceramic material, total fill, and I was trying to insert the material in the root canals. But as you can see, it's quite difficult to get it in the right place. So you have to take a plugger. And as I showed you previously with the Eins case, you have to take sometimes ultrasonic device to condense MTA. You can also mix with a MTA-based sealer, which Total Fill has, and you can take bioceramic putty to condense and fill all the root canals with bioceramics or MTA if you still prefer MTA. So this is how I did. I filled all the root canals with only with bioceramic material. I was not using at all gutta percha in this time. So, but you have to condense very, very well, and this is not a very easy task. So as we know, the material needs some moisture, so I covered with moist cotton pellet, and I put some cavit or temporary filling material over the cotton pellet. You have to get rid of all the cotton fibers, so otherwise there will be like highways to microbes to go in the root canal, and I fill with glass ionomer cement. So I will condense it, and this is the X-ray right after root canal treatment. So I was already telling you it's difficult, and you have to be very precise with the root canal filling. So one by one, the root canals must be filled. I always take an X-ray, a small X-ray, periodical X-ray, right after I have filled each root canals, because if I can see some mistake, I can correct it quite well. So this is a mesial system that is filled. So now all of them are filled, and this is how I saw the patient next visit. So the next visit you can make after 4 hours, but of course logically you cannot book the patients like this. Usually it takes about a week or 2 weeks, or sometimes even more, when the patient is able to come back to the office. And I have to take away all the temporary filling. I have to take away all the moist cotton pellets, and then we can touch and check of the hardening of the MTA-like material, or the MTA by itself. If necessary, you can clean it. This time I was very happy, because bioceramic material was well hardened. You can see with a probe, it's very hard. So we can continue with our treatment. So in this case, I was using fiber reinforced composite to get some inner force, or let's say stability, and then filled the rest of the cavity with regular composite. So unfortunately, I saw a void in palatal root canal fill, but I was not too afraid or too worried about it. So I made the preparation of the core. I made a temporary crown. We took a color photos for the lab. We put on the temporary crown. Next visit, we remove the temporary crown, and we will put a final crown, which can be made of different materials, as you all know. But my preferred choice, usually after endodontic treatment, is multi-layer katana material. So this is right after cementing, and this is a posture of CBCT. So this is a controlled CBCT, where you can see total resolution of the sinus problem. So we don't have any sinus problem. So we know that endodontic treatment is working very nicely, even in those very difficult situations, and even in situations that usually the first thing that is coming our mind is extract the tooth and maybe wait and put a delayed implant, or a simultaneous implant instant. But in this case, I think I made a right choice, and I made a endodontic treatment and the prosthodontic treatment, and the patient is happy even today. So this is 2 years post op CBCT. So you can see some photos also, or screenshots of the CBCT, and you can see there is absolutely no problem regarding of the root. So the next case is a case of Heikki. Heikki is a very nice patient, and he came to my office in 2016. So he came with a referring note, which was in last slide, but it was in Estonian, so I will explain it in English a little bit. So the patient has had already quite a long time ago made endodontic treatment, so 7 years ago. So the first endodontic treatment was made in 2009, and the referring doctor referred this patient to me, saying that you can see it's 7 years old endodontic treatment, and the patient is still symptomatic, and you can see the endodontic treatment is done not so bad. But when I'm seeing these kind of cases, I always see that there are a lot of voids in root canal fillings. So we have a big periapical lesion, and I'm an endodontist. I know that I can save this tooth. I know that I will do a retreatment of this tooth, and I can surely save this tooth. Patient was ready and happy to try to keep the tooth, and that's why we started the endodontic treatment. So I isolate the tooth with rubber dam again. I made an excess cavity, and I can see already that there is endodontic treatment problem made in the tooth. There is not the proper orifice barrier, so we have a leakage. And if we have a leakage through the material, through the composite, we know that endodontic treatment will fail. So I removed all the filling to make the correct access cavity. I removed all the root canal filling, or at least I tried to remove all the root canal filling. It was really difficult because the patient had a limited mouth opening, which is, I think, one of the most difficult situations where you have to do endodontic treatment when the patient is having limited mouth opening. And of course, retreatment or endodontic retreatment is always more difficult than the primary endodontic treatment. So we can see 4 different root canal entrances here. I tried to clean them all as well as I could. And after first visit, I put some calcium hydroxide in the root canal again. But still, I can see some parts of old gutta percha and sealer in the root canals. And I know that I have to clean it more and more. So the patient came back, and I did again the cleaning and chemomechanical debridement of the root canal systems. But still I can see in the mesial canal, I can see some old gutta percha filling and sealer parts. And still I don't see any kind of resolution of the periapical lesion. Of course, it's not enough time also. Not enough time has passed. But we know that it's not so important how long time must be passed, but how clean the root canal system should be. So I cleaned it as good as I can or could at this time, and I started to fill the root canal system again. So I filled the root canal system with, again, the same method I showed you with the layers case, only with bioceramic material. And I tried to condense it very well. Unfortunately, again, I overfilled the distal canal and underfilled the mesial at the first time. And then I tried to condense it more, so I filled the mesial canal also better. So this is now right after root canal filling on the left side. So this is May 2017, and after that, we next visit again. As you can see, we exchange the cotton pellet, we exchange everything temporary, and we filled everything with a composite. So you can see already, you can start to see that there is a little bit resolution of the apical periodontitis. So there is some bone formation around the root tip. So this is 2017 on the left side, and this is recall 2019 on the right side. So we see that there is the situation is getting better. So it's not perfect yet. The healing is not absolutely, but we have a bone filling, and we don't have any more periapical lesion. And it looks like it's getting better. So, but the patient came back with some symptoms in 2019 in September, and was telling that I still kind of feel the tooth, and maybe there is still something problem. Maybe you can see and check. I made an X-ray, and I saw that yeah, maybe it's not so good anymore. But still, I was not totally unhappy with the case. And I was telling that let's wait if you can live with a tooth. Let's try to keep it. Maybe we can put a crown on it. Maybe the filling is little loose or something like that. But again, couple of days ago, to be honest, the patient came back to my clinic with an emergency case. She had a big swelling a couple of weeks ago when he couldn't attend the clinic. So he came, and we could see abscess in the apical area. So I know that the tooth is lost now. I made an X-ray, and what we could see, we could see the distal root is, yes, it's okay. Even though it's overfilled, it's not a problem. We had a problem in mesial root, and the mesial root, not with endodontic treatment by itself, but with a vertical root fracture. So now we know that we don't have any more possibility to save this tooth, and we have to extract it. Okay, this is exactly what I did, and we told the patients that it's impossible to treat it anymore. We have to extract it, and we have to put an implant. So this is our plan for the next month now. So this was the cases of my endodontic treatments, how I do it, and what are the limits of endodontic treatments. So next case, I would like to show you again a long-term patient of mine. His name is Alan, and he is missing, he has a lot of problems in his mouth. He's my long-term patient. So I started treating him in 2004 when I was in postgraduate, when I was a postgraduate student in my professor's clinic. I did an endodontic treatment. In 2004, I was using hand instruments, stainless steel hand instruments, tooth number 15 and tooth number 16 had already, in 2004, had already previous endodontic treatment done, and I was retreating those teeth. So I did a treatment, and this is the first digital X-ray I have from him, and it's from 2012. So he came to my office. He had no problems, but I always check all my endodontic treatments, and I saw that this situation here is not so good. So I started to explain to the patients that we have to do something about those teeth. We have to extract them. We have to sinus lift the case. We have to put some implants, but he refused. He refused just because he had absolutely no problem. No symptoms, no swelling, no nothing. So he was living nicely, and again in 2016 in December he came to my office with other problems. I again made a periapical X-ray to check what is the situation. We remember the case in 2012 and this is 2016. It's pretty similar situation. So the patient had no problem, no symptoms, no nothing, and was living quite nicely with those endodontic treatments and prosthodontic treatment also. But we can see that this is not a perfect situation. This is a situation clinically. So we have some porcelain fused metal crown, which I was doing in 2004 mostly. Yeah, maybe the color is not perfect, and maybe the fit is not perfect, but the patient had absolutely no problem. He had his teeth, he could chew on them, function was perfect, and he was happy. So again, this is now 2019, so 2 years after the last X-ray, and now we see problems much closer. We see not perfect endodontic treatment at all, and we see some lesion between roots on upper 6 tooth, and some periapical problems also. So on that time, I already had an CBCT machine in my office. I could make a CBCT, and I could saw what's a real damage, what's a real problem. So now what can I see? I can see that the teeth are elongated a lot. We can see the elongation of the upper 6 because of the periapical lesion and the furcational lesion. And we had to grind the tooth down a lot to get rid of the elongation or to get rid of the bite. So, and we had to take out of those 2 teeth. So we had no other problem. And we planned for implants. Now, we were very happy that we could see the width of the bony crest was very wide. So we're happy, but not so happy with the height of the crest in 8 millimeters. So it's not very little, but it's not the best also, as we know. So what are our possibilities? Our possibilities would be to put a long implant, but if we want to put a long implant, we have to make a sinus lift, and the patient was not so happy about the sinus lift. I told him that maybe we have to make the sinus lift, and he said, okay, if you have to, you do, but if you can avoid, please avoid the sinus lift. So what I was thinking on that time, I was thinking taking wide implants like 5 or 5.5 millimeters and some short implants like 7 millimeters. And I tried those implants. I played with my X-ray software, and I thought that yes, in this situation, quite short and quite wide implants can work, I think, quite well. So this was my choice. So this was also the time when I started using the Megagen AnyRich implants, which I think it's really very good implants. I have used different implant systems in my not so short career anymore, but at least a short implantology career, I would say. So we can see a clinical situation. The situation is 3 months or 4 months after tooth extraction, and now we know that we have to put some implants. So this is how the clinical situation is looking from different angles. So like we planned, I was using freehand surgery in this time, and I placed 5 millimeters in diameter implant in position 1.5 and 5.5 wide diameter implant in position 1.6. And the implants were short, only 7 millimeters long. And with this approach, I was able to avoid using sinus lift in this case, even so we could have done it also. So we closed the gingiva. We made it so-called delayed healing of the surgery. Why I did it? Because this was basically the first case in my career when I tried this wide and this short implants. And I was not certain of myself. That's why it's a closed healing. So this is right after surgery. So this is made last year in December, if I'm not mistaken. surgery. And we can see quite precisely that we are touching the sinus floor but not penetrating it. So we could avoid sinus lift in this situation. And the same goes for 1.6 and 1.5 tooth. So again, this is 1.6 here. So this is this year May. The patient came back. He should have came a little earlier, but because of the situation, we could not schedule him any sooner. So, but he came back now, and we made an periapical X-ray, a small X-ray, and we can see a very well, a very good situation. No sinus trouble, at least from this two-dimensional X-ray, and we can see some bony overfill of the implant collars or heads. So I opened, I made an incision, and I opened the implants. I had to take a little bone away. I had to use some osteotomy, and I was using Megagen scan healing abutments. And we closed with secondary healing situation. So I used a scan healing abutment. I think it's a very, very nice, nice choice from Megagen. I have done now a couple of cases with this scan healing abutment, and it's very nice to save some time during the treatment, and the patients also really like those things that you don't have to screw so much in the mouth and you don't have to make anesthesia sometimes. So it's much more easier. So the next implant case I wanted to show you again is an Enrich case. This is case of Merily, very nice lady. She came to my office actually with a problem of the other side, and we started a couple of I think a couple of years ago already. We put some implants and things, but also she was complaining about the sinus problem on her left side, and some runny nose, and sometimes she had some pain from teeth from the upper left side. So as we made an CBCT anyway, we could saw periapical lesions around two teeth. We could saw periapical lesions around tooth number 2.8, and we could see also a problem around tooth number 2.6. So the first and the third molar had periapical lesions, and as she was very happy with previous treatment, she told me that she don't want any endodontic treatment on those teeth and she wants to take them out. So we took out the tooth number 2.8 and 2.6 because of periapical lesions, because of symptoms. So this is a situation after 3 months. She had she has also congenitally missing tooth number 2.5. So we have actually a bigger problems that I was understanding at the first place. So I did a lot of measuring. So we can see the bone is quite good. We have good enough height. We have good enough width of the bone. Of course, every surgeon wants to have more bone, but let's say it's at least adequate to place an implant. So what I'm doing now is let's say almost every case, not 100% of the cases, but almost every case, I make a CBCT and I make an intraoral scan. I use a Medit scanner at the moment, sorry. I take upper and lower arch models, digital models and the bite. So, and all the data is going to AutoCAD software. To be totally honest, I'm not doing the planning myself, so I let my lab do the planning. I really do like my working with my lab. This is a dental lab situated in Tallinn, Estonia. So you can use their work, I'm sure, everybody all over the world. So you can send the digital data like CBCT data, intraoral scanning data to the dental lab, and they will make a perfect planning for you, and they will send you the plan, and you can look it through. You can make some adjustments if necessary, and you can replan or accept the plan. So in this situation, the plan was, in my mind, very good, the best we could do in this situation without orthodontic treatment, and she did not want any orthodontic treatment, so we planned only to replace one tooth. And as you can see, I'm using AutoCAD the light version. As a Mac user, this light version is easier. And I think the light version of AutoCAD is good enough. It's very good. It's very well visible. It's very handy. And you can make small adjustments quite easily if necessary. And it's not getting too confused. Of course, if you are planning big cases, if you have by profession an implantologist or implant surgeon, and you do it every day, like tens of cases, and maybe AutoCAD Light is not for you. But for me, it's very easy and nice. What else is good with AutoCAD and also digital planning is I'm only doing the work, and my administrator and assistant is sending all the data to lab. So I'm not busy with sending data and taking too much time in facing the computer and planning and doing things. So my assistant is sending the data, and lab is making most of the plans. And usually I will, not usually, but always I will check always the plans. And most of the cases, I even don't make any changes. Maybe sometimes a little. Of course, you have to check it always, because you have to accept the plan, and then the lab can make you all the necessary things for future. So next step is that the lab is making you a stent surgical guide, and they can make you a temporary crown in front. So in the same time you make a surgery, you can put also the temporary crown. So you always have to check the surgical guide. It has to fit perfectly. You have to see the fit. You have to check the fit. And I can say dental lab guys are making the surgical guide perfectly. So very little cases, very few cases I have to do something to fit the guide, but I would say more than 95% of the guides are totally perfect. So again, so we can see the fit. So, and this is a time of operation. So we can fit the surgical guide, as you can see on the left side, and we can make incision like is necessary, like is what you think. As I'm not a totally implantologist, I'm not suggesting to choose this or this kind of incision or different kind of flap design, but this is how I did it this time. I did it because I wanted to make some augmentation also. Otherwise, I would have made flapless surgery in this case. So this is the steps of the surgery. You can see, you can take the guide out. Yeah, you can see what is the situation of the drilling, where is bone and where is not so much bone. So this is an implant we choose. And now is very important part. If you want to use temporary crown on the same session, same time when you operate, so immediate loading, you have to put the implant in correct depth and in correct angulation. So that's why you have this special key, special driver of the implant. So you have to check the vertical and hex position here. So you have to see the green right in between those slots, and the height has to be exactly on the same level. So the same level, and my advice would be same level or just a little deeper if possible also. So this is a depth control with a perio probe, and there are two things we have to think about when we want to make immediate loading. The first would be insertion torque. So the torque must exceed 45 Newton centimeters for sure. It could be better that it's even more. And the second is to check the ISQ, so implant stability quotient. So I'm using a penguin device for the implant stability, and again, it should be over 70 if we want to make a single crown. So you can see we had a good torque value, and we had a good ISQ. The torque value was over 45 and ISQ was over 70. So we could use on the same time, again, we could use a temporary crown. So the ISQ value, as I told you, must be more than 70 to put a immediate loading on the implant. And then we inserted as a temporary crown. The screw type is my preferred choice. And also I wanted to make a little augmentation. I made the augmentation with ethos material. So this is a material that doesn't need a barrier. And that's why I really do like the material. We don't need any membrane of the ethos material. So I filled the area with ethos material. It's not wise to overfill the augmented site, but to make it maybe just a very little overfill or not no overfill at all. So this is an ethos mixture here on the site, and we try to close the wound. It is quite important that there would be a tension-free closure of the surgical site. Unfortunately, I was not able to get this in this situation, of course, because I was not so I'm not so good of the flap surgery, but we had some day senses. So again, this is not a very big problem, but it's advised. I would advise to avoid it if possible. So now we filled also the screw hole on the temporary crown. We are using Teflon tape, and I'm using self-edge composite like Revies flow, for example. And this is next visit, so it's 8 days has passed from the surgery, and it's time to take away the sutures. So we can see we have some dehiscences because of the flap design, but I'm quite sure that dehiscences will resolve we resolve a little, and we can get a little bit better situation after some months. So now she's waiting for the final crown. She will come back to my office, I think it was next month, and we will take away the, next month, and we will take away the temporary crown, and we will take a final scan, and maybe if I have to do something with the soft tissue, maybe we will do something with the soft tissue also before the final crown, but let's see. So this is again one case I wanted to show. This is case of Gunnar. Gunnar is a very nice gentleman. I did the surgery just a couple of weeks ago. Already, also you can see a photo here of me giving my first Megagen lecture or Minec lecture about my way, or how did I arrive to the Megagen products. So at the moment, I think I have used different implants systems in past, but I think at the moment it's the best system I have in my office. So also I really do like again possibility of artugate and guided surgery, which gives a perfect position of the implant. So we don't have to have any problems with angulation. Like for example, again in this photo, I am just talking about the angulation of the implant, which is made here on the screen, the freehand, and this might be a problem in the future. So, and guided surgery gives them much more confidence of succeeding. So this is a Gunnar's case. Gunnar is again referred patient in central Estonia, so only, let's say, 40-50 kilometers away from Tartu. And she was referred, and she asked that maybe I can do something with the second molar. So second molar in both sides, second molar 3-7 and second molar 4-7 tooth. And what was our plan? Our plan was to treat 3-7 endodontically, and our plan was to check the 4-7. When I saw the panoramic X-ray, as you can see that there is nothing to do with the tooth. The tooth has previous endodontic treatment here, and also we can see vertical root fracture actually already even on the panoramic X-ray. So this is a clinical situation. The patient has no first molar, and the second molar has a root fracture. So when we take a perioprobe, we can put the perioprobe right to the apex of the tooth. So we know we have absolutely nothing to do in this situation, and we have to extract the tooth. So this is the situation after extraction. The patient was very unhappy with extraction because it was a long healing time for him, and he also felt always some bony chips coming out, and he was aggressively rinsing the mouth and not maybe letting the site healed by itself very well. So anyways, we still thought we could go ahead with implant treatment in this situation, and our plan was to put 2 implants. So the first implant inside 4.6 and the second implant to put on the side 4.7. You can see the alveolus in 4.7, and you can see the bone situation is actually very well. We have a lot of height, and we have a lot of width also. So this is almost like a perfect situation. Even so, on the clinical picture, we could saw a big dehiscence, but on the X-ray we can see actually there is a lot of bone under the gingiva. So this was my plan. First, when I played it through, I thought I will put 10 millimeters implant and 4.5 diameters. So this is the second plan already, and we ordered a final surgical guide from Artgate lab, from dental lab from Tallinn, Estonia, and we could get a very nice work from the lab. The surgical guide was fitting very well. And we could show that sometimes you have to push the guide because it's so precise. You have to push a surgical guide from the occlusal side very, very hard. So because of the bone level was very good on the X-ray, you can see the dehiscence on the first molar side, on the buccal side, but on the X-ray, the bone level was really, really good. We decided to make a totally flapless surgery. So these are the real implants that I was choosing, or what was the plan on the Artgate plan. The 4.7 was 4.0 implant and 11.5 millimeters, and the, in position 4.6, that was 4.0, 13 millimeters implant. So again, we have to check and double check, and I will say even triple check the position, the hex position, and the vertical position of the implant. And as you can see, I really, if it's possible, even to put the implant a little bit deeper than the position. Maybe this time was a little bit too deep, but this is my experience that putting the implant deeper is a little bit better. Of course, you have to avoid all the anatomical problems that can occur. You have to have room. Again, we will have insertion torque of the implant. It has to be more than 45, and we have to make ISQ, which has to be more than 70 to put a single implants. Sorry, not single, but implants with single temporary crown, so immediate loading. If the insertion torque is less than 45 and the implant stability content ISQ is less than 70, you can splint the teeth. You can splint it using adhesive technology, but very good adhesion must be achieved. So my advice is to use edge-etching, bonding, and then composite. Not only self-etch composite or something very easy, because edge is not, the bond is not good enough then. But in this case, I had a very nice ISQ, and it was over than 70 for sure. It was close to 80. And also the torque value was more than 45. So I have to mark always my pieces, what I want to put in the mouth, so my temporary crowns. So 4.7, 4.6, my assistant is always marking them, because otherwise I can get confused which crown belong to on which implant. So I try to mark them very well and try to put them one by one. So this was a situation on the left hand after implants. So I tried to put implants in the, sorry, not implants, but temporary crowns on the implants. But unfortunately, they were not going deep enough, as the gingiva was disturbing. So I made some vertical incisions on mesial and distal parts of gingiva of the implants, so I could expand gingiva a little and insert the temporary crowns. So on the far right side, you can see both temporary crowns on the implants. And this is how we finished. What is very important, of course, we have to take the temporary crowns out of occlusion. So with a color checking, it's very important, color paper. It's very important to check that there is no marking on the temporary crowns, and if there is, you will just have to drill and polish them away. So now we can see we don't have any contact points on the occlusion, and we can be happily say that this is a successful treatment, and the patient can now go away from our office with quite high confidence. So this is the implants I used, and those are the abutments that were used by dental lab technicians. So this is exactly right after procedure. I always make a small, not high, but low definition CBCT after surgery, just to check the implant position, and was it exactly like we planned, or was it a little bit different. So in this case, the implant positions were exactly like we planned, and the positions were very good also. So this is, now you can see both implants, and also I made an periapical X-ray. So 13th of May was the time when we made a surgery to the patient, and those are the abutments used also. So I thank you. This was a lecture. I tried to tell you. We will have some more conferences in future, I hope. I'm very honored that I was asked again to the conference in Estonia. I can share the podium with great lectures and great professional doctors like Dr. Ifan Abbas and Dr. Miltiadis Mitsias. On the same time, it's really big honor for me. So in October, hopefully we will have the conference in Tallinn, and I'm sure if somebody wants to come, then please feel free. So this was my lecture. I'm an endodontist, so I want to talk about implantology. I hope you understand that there are different ways of getting to the same place, and sometimes one is better than other, but we have a lot of times when we can choose, and we have to choose very wisely, not to crash or sink through the ice road. So I thank you again, and goodbye.